For those of you who just got in, my name is Luca Dompieri. I'm a fifth-year medical student at the Federal University of Pernambuco, here in the Northeast region of Brazil. And I'll present my work here under the supervision of my professor, Dr. Simone Brandão. And it's such an honor to be here. I'm grateful. It's an amazing opportunity for me as a student to be part of this webinar and present my work here for such an audience. And so I'll begin here the presentation called the FDG PET CT in the assessment of cardiac tumors. Wait a second, let me. These will be the topics that I'll go by during the presentation. I'll start with the case report, a brief presentation about a case report with a minor discussion regarding the case. And I'll go on with the revision article that was part of my scientific initiation program with Simone. I helped her write this revision article about the FDG PET CT applications in cardiac tumors, focusing on the differentiation between the benign and the malignant cardiac masses. So let's begin. Before I begin with the case, just a brief story about how this came up, about this case report. We are here in the Northeast region in Recife, Pernambuco, me and Simone, but actually the patient is from Espírito Santo, here in the city of Vitória. Simone got in touch with the assistant physician of the patient by a WhatsApp group, the Brazilian group of Cardio-Oncology. They sent the case in the WhatsApp group to discuss, and Simone created this connection. And so this connection between the Espírito Santo and Pernambuco, we came up with this case report. Just published in January on the Canadian Journal of Cardiology. It's called the Cardiac Malignant Peripheral Nerve Sheath Tumor Assessed by the FDG PET CT, written by me and Simone and the other authors from the Espírito Santo. So to begin, a brief introduction. We know that primary cardiac neoplasms are rare. They present an estimated incidence of 0.001 to 0.03% in the general population. And among the malignant primary tumors, the malignant peripheral nerve sheath tumor is extremely rare. We have only a few case reports about it in the literature, so it's a rare entity. But as in any cardiac tumor, cardiovascular imaging is crucial for the characterization and management of those tumors. And in the field of cardiovascular imaging, the FDG PET CT is a useful method that provides imaging of the tumor's metabolic activity and is able to detect a malignant mass and also metastasis sites. Now the case is about a 52-year-old man presenting with palpitation and moderate dyspnea for 2 weeks. The physical examination showed blood pressure at 120/80. The heart rate was 88, and he had a fourth heart sound at auscultation. He had a medical history of hyperlipidemia and a previous parathyroidectomy 8 years earlier due to a malignant tumor, but unfortunately we don't have any more data, any more information about this malignancy. He had no significant laboratory abnormalities, but the electrocardiogram, I think you can see, the image is not really good, but had sinus rhythm, first degree atrioventricular block, P waves inversion in D3 and AVF, and there's also a poor R wave progression in V1 to V3. So the investigation proceeded with the cardiogram. Here we can see a 4-chamber image with the mass measuring 75 by 39 millimeters in the interventricular septum. So this called for a magnetic resonance, the CMRI. There was no signs of obstruction on the left ventricle outflow tract, and the ejection fraction was preserved also. But the tumor presented some specific tissue characteristics. Here on the short axis cut, we can see in the image the CMRI had undefined borders and an heterogeneous pattern. The T1 and T2 weighted image had an hyperintense pattern without signs of fat saturation. There was also heterogeneous late myocardial enhancement, as we can see here on the left, better observed on the tumoral periphery. And on the right, the first passage perfusion was partial with no central perfusion. The central region of the tumor probably had necrosis. Now we went on to the FDG PET CT. Here we can see the whole body scan showing an important cardiac mass with significant uptake. On the yellow arrow, the submax calculated at 13.4, and it showed also multiple high uptake sites on the red arrows corresponding to metastasis sites. Among various sites of high uptake, various spots of metastasis, this lesion on the myoadipose region on the back of the patient, presenting an uptake, a submax of 8.8, was chosen to perform an incisional biopsy, and in a way to spare the heart from an invasive procedure and perform the microscopy, the microscopic imaging. On the left, the histopathological analysis. On the red arrow, we have the tumor area showing a typical fusocellular proliferation with pleomorphic, multinucleated, and anaplastic cells. And the yellow arrow showing necrosis and infiltration on the adjacent tissue. On the right, we have the immunohistochemistry, which tested positive for the CD56 clone 123C3 and also the Ki67 antigen, and it confirmed the grade 2 MPNST, the malignant peripheral nerve sheath tumor. So the patient underwent 3 cycles of ifosfamide with one of docetaxel, but unfortunately he deceased after showing symptoms of a rapidly progressive heart failure about a month after the last cycle of chemotherapy. So what we know about these kinds of tumor, the malignant peripheral nerve sheath tumor, they are soft tissue neoplasms from the peripheral nerves. They usually arise from the trunks of major nerves, such as the sciatic nerve, but there's no specific immunohistochemical or genetic markers. They have complex karyotypes and present a lot of numerical and structural abnormalities. So the diagnosis can be challenging and can be difficult by these factors. And on the heart, they usually rise from the cardiac plexus and also branches from the vagus and the phrenic nerves, and may cause heart failure, arrhythmias, cardiac tamponade, dyspnea, peripheral embolisms, and signs of superior vena cava syndrome. The electrocardiogram, the same as presented in our patient, may show STT segment alteration and atrioventricular block. And as I said before, cardiovascular imaging is crucial for the characterization and management of those cases, and the PET-CT, the FDG PET-CT, is important to assess those tumors. In this study, comprising 47 non-cardiac MP and ST patients, the FDG PET-CT was important to restage the patient, and it changed the initial diagnosis and the initial staging, and so the treatment in 31% of the cases. This is a very aggressive tumor, does not respond well to chemotherapy and radiotherapy, so the therapy of choice is surgical resection. If there's a unique and a single lesion, single tumor, well defined. But even that, the prognosis is still poor due to the tumor's aggressiveness. Up to 60% may present with recurrence after surgery, and 30 to 60 may develop metastasis. So the current case demonstrates the importance of the diagnostic approach of various cardiovascular imaging methods, focusing here on the FDG PET-CT, which in this case correctly identified and staged the tumor, and in a way to avoid a risky heart biopsy and properly guided the management. Here, to go on, here's the revision article that I was writing with Simone, published last year in the Brazilian Journal of Cardiovascular Imaging. It's called the FDG PET-CT applications in cardiac tumors. Will give us a broader discussion about the applications of this method in the various types of tumors. So a little epidemiology about cardiac neoplasms. As I said before, they're rare, and that they can be divided into primary and secondary. The secondary are 20 to 40 times more common than the primary ones, and they're usually metastases from lung cancer, breast cancer, leukemia, melanoma, lymphoma. These are the most common types of cancer that can produce metastases to the heart. And the primary tumors, as I said, extremely rare, with this incidence 0.001 to 0.03%, can be divided into benign tumors and malignant tumors. The benign tumors correspond to 75% of the primary, being the myxoma the most common one. Half of the benign tumors are myxomas. And the malignant tumors, the most common one is the sarcoma, followed by the primary cardiac lymphoma. So as we saw in the case, cardiovascular imaging is crucial, plays a key role in the characterization, the initial approach to these conditions. And the echocardiogram is the initial method, and it can be improved by tools such as contrast, three-dimensional images, and strain. The CMRI and the computer tomography may provide additional information on the anatomy, on infiltration of the adjacent tissues, some specific tissue characteristics of the tumor. And the more advanced method, there's the FDG PET-CT, providing images of the tumoral metabolic activity, the tumoral uptake on the FDG marker corresponding to the glycolytic metabolism. It's widely available, widely used on the secondary tumors, the metastatic tumors, which are more common. But on primary tumors, we still have limited experience, but we'll see how it goes here. So in order to understand the FDG application in cardiac tumors, cardiac masses, we must understand the FDG uptake in the heart, the cardiac uptake. And it depends on factors, and three main factors, which is the glucose level, the free fatty acid level, and the insulin level. So when fasting, there's a decrease on the insulin level, which increases the lipolysis and the fatty acid level. And it decreases the glycolytic metabolism, and so the FDG uptake, it's decreased when fasting. That's why it's recommended to fast for 6 hours, at least 6 hours before the exam, to reduce the myocardial FDG uptake in order to create a viable contrast between the normal tissue and the tumoral tissue, which when present signs of malignancy may present a higher FDG uptake. So on the matter of the differentiation between the benign tumors and the malignant ones, we performed the research on the PubMed databases using the terms FDG PET-CT and cardiac tumors from 2009 to 2019. And we came up with 39 case reports, 3 case series, 2 revision articles, and 2 retrospective studies. These are the case reports. We organized them in this table, the 39 case reports. There were 19 cases about metastatic tumors, mostly tumors from lung cancer, melanoma, lymphoma, as I said before. And we calculated a mean uptake, the mean max of those tumors, which in these cases was 8.3. Among the primary tumors, there were 20 tumors, 3 being benign tumors with the mean max of 2.5, and 17 primary malignant tumors, mostly angiosarcomas, lymphomas, and primary cardiac lymphomas. And the mean max in these cases was 12. Okay, and here we have the retrospective studies. The first one by Rabar and his colleagues, published in 2012 on the Journal of Nuclear Medicine, comprised 24 patients with cardiac tumors, 7 presenting benign tumors, and 17 malignant tumors, being 8 primary malignant and 9 secondaries, 9 metastatic tumors. The other study by Shao and his colleagues, published in 2011 in the Journal of Nuclear Cardiology, studied 23 patients, 10 with benign tumors and 13 with malignant tumors. The image analysis of both studies was similar. They started with the computed tomography, using some morphologic characteristics, using 7 morphologic features of the tumor to classify the tumor as malignant or not. If the tumor presented 3 or more of those features, it was classified as malignant. Then they moved to the FDG PET-CT, calculating the maximum standard uptake value, the submax, for the significant areas, the normal tissue here, the blood pool, the myocardium, which presented the submax of 1.6, the blood pool, and 2.1 at the myocardium, and the tumors, which presented in general, not differentiation, benign and malignant, a mean submax of 7.5. So now focusing on the benign tumors, as I said before, the myxoma is the most frequent primary tumor and may cause symptoms mostly related to the size and its location in the heart. So it may cause obstruction, arrhythmias, valve dysfunction, produce thrombus. And since it's a benign tumor, presents little to non-FDG uptake on the PET-CT. The lipoma is another benign tumor with also no FDG uptake, and the lipomatous hypertrophy from the interatrial septum is a condition that may present an increased FDG uptake, may range from 0.5 to 3.5. This is probably due to the brown fat constitution that may present some glycolytic metabolism. On the Rabar study, he had 7 benign tumors, 7 patients with benign tumors, and the mean submax was 2.8. And the Shao and colleagues study with 10 patients presenting benign tumors. He established a submax cutoff point at 4, and it detected correctly 9 out of 10 patients with benign tumors. This cutoff excluded one patient presenting an active pericardial tuberculosis, which showed a higher uptake than the benign conditions. Among the case reports, we had only 3 benign tumors presenting a mean Cevmax of 2.5, and this case series showed 3 benign tumors, 1 lipoma presenting a Cevmax of 0.9, 1 fibroma of 6.8, and this other benign tumor with a Cevmax of 2.6. Here we have an example of how the PET-CT complemented and helped the differential diagnosis of a cardiac mass. This 59-year-old woman presenting with pericardial and pleural effusion and chest pain had a tumor showed in the computer tomography and the MRI with malignant characteristics. It presented contrast enhancement, hypervascular pattern on T2, and with the pericardial effusion, it was doubted if it was a malignant mass or not. So they went on to the PET-CT, and it showed no FDG uptake here on the B image. And later, the diagnosis by biopsy confirmed benign condition, hemangioma. About the primary malignant tumors, they usually present high FDG uptake, but as I said, the diagnosis may be difficult when there's conditions with high myocardial uptake of the marker of the FDG. Because as I said before, the normal myocardial FDG uptake may depend on those features such as the glucose level, the insulin, and the fatty acid level, and it's not regular, it's not uniform, the normal myocardial uptake. So there are times that can difficult the diagnosis. On the Rabar study, he had 8 primary malignant tumors with a Cevmax ranging from 5.3 to 10.7, and using only the CT, he misdiagnosed one case of an angiosarcoma, which later was correctly identified by the PET-CT presenting high FDG uptake. The Shaw study had 13 patients with malignant tumors, and his cutoff at 4, the Cevmax at 4, correctly diagnosed all malignant tumors. Among the case reports, 17 primary malignant tumors presented a mean Cevmax of 12. This case series showed 3 primary cardiac large B-cell lymphoma with Cevmax of 26, 29, and 22. The other case series of primary angiosarcomas presented high uptake of 36, 8.8, and 17. The metastatic tumors, the secondary tumors, are usually related to disseminated metastases from a kind of cancer. And the FDG PET-CT, providing a whole body scan, is useful to identify not only the primary tumor with a high specificity and sensitivity, but also detect metastases. Here we brought an example, a case from our service, from the Hospital das Clínicas, about a 37-year-old man diagnosed in 2016 with a melanoma in the chest. By the time he underwent the surgical resection, but 3 years later he returned with multiple subcutaneous metastases. So he did a PET-CT for restaging, and it showed this image with multiple metastases, including one in the left ventricle, pointed here by the arrow, with an uptake of 8.7. And unfortunately, the patient deceased 30 days after this exam. Among the metastatic tumors, it's important to emphasize the lymphoma. which may present cardiac involvement in 15 to 13%, 30% of non-Hodgkin lymphoma cases. The FDG PET-CT in a way is useful to not only the initial staging, but also in the post-treatment and during treatment evaluation. So the Shaw case series showed 7 cases of lymphoma and leukemia which were correctly diagnosed by the FDG PET-CT. Here's an example from Dr. Paulo Almeida here in the Hospital Português, also in Recife, about a 77-year-old man presented with a non-Hodgkin lymphoma. He did a pre-treatment exam here for initial staging, and then he repeated the exam during treatment, showing the metabolic response on the treatment with a significant reduction on the uptake on the cardiac lesions. The RABAR study, he had 9 patients, as I said before, with metastatic tumors, and the mean submax was 10.8. It ranged from 3.4 to 16.7. We see a wide range of uptake among the metastatic tumors. In this case series, using only the CT, he misdiagnosed 2 cases, one of metastatic pericardial tumor, another from a chondrosarcoma, which were then correctly identified by the PET-CT, presenting a high uptake. Among the case reports, only 12 out of 19 cases about metastatic tumors presented complete data regarding the FDG uptake, and the mean submax of those tumors was 8.3, with the big standard deviation at 10.3 standard deviation also showing this variability on the uptake among the metastatic tumors. Now, in order to validate the FDG PET-CT as a diagnostic test on the approach in cardiac tumors, it's important to establish a cutoff point on the uptake value. Here, this graphic, we see the standard uptake value by the different kinds of tumors, and we see a significant difference between the benign tumors and the malignant tumors in general. And probably around here, 4 to 5, it's a good point to establish a cutoff. Among the malignant tumors, it's not significant, the uptake between the primary malignant and the secondary malignant, but the importance here is the difference between the benign and the malignant ones. We can see here the variability among the uptake on the secondary tumors. Right here we have the blood pool and the myocardium uptake, which is similar to the benign tumors, a very low uptake when compared to malignancies. Okay. So the RABAR study established first the cutoff at the mean submax of 3.5. So using this cutoff, he reached 100% sensitivity with 86% specificity, a 94% positive predictive value, and 100% negative predictive value. When he raised the uptake, the cutoff to submax of 4.6, the sensitivity decreased to 94%, and the specificity raised to 100% with 100% also PPV and NPV. The Shaw study, as I've been saying, established the cutoff at 4 with 100% sensitivity and a 90% specificity, 92.9% PPV, and 100% NPV. So to the computer tomography, using only the diagnostic performance of the morphologic features of the computer tomography, we can see here each feature in alone and its performance, and here the 3 or more features which was able to classify the tumor as malignant or not using only the computed tomography. Using these features, the sensitivity was 82% with an 86% specificity. When you added the metabolic data of the PET-CT, the sensitivity went to 100% with the same 86% specificity. Summarizing, the FDG PET-CT improved the sensitivity and the accuracy of the differential diagnosis. Among the benign tumors, the SHAO study, all 10 patients with benign lesions were correctly diagnosed with the CT, while the PET-CT misdiagnosed one case of pericardial tuberculosis. While in the RABAR study, the CT misdiagnosed one case of hemangioma, which later was correctly identified by the PET-CT, as I showed you in the example. Among the malignant tumor, comparing the CT with the PET-CT, the SHAO study established his cutoff at 4 and correctly diagnosed all malignant tumors, all 13 malignant tumors, while the RABAR study, the CT misdiagnosed 3 malignancies. As I said, 1 primary tumor and 2 metastatic tumors, which were correctly diagnosed by the PET-CT, which correctly diagnosed all 17 malignant tumors. So we used this cutoff at 3.5 in the case reports and case series. Most of them would have been correctly diagnosed, with 2 exceptions: 2 benign tumors, 1 myxoma, which presented a Cevmax of 5.2, and 1 fibroma, which presented a Cevmax of 6.8. Among the malignant tumors, none were below the cutoff point. Of course, there are still limitations on this data, both retrospective studies, and we have only 2 retrospective studies and case reports and case series. So, and the retrospective studies may present potential selection bias. We have few benign tumors assessed by the FDG PET-CT, probably because most of the benign tumors are correctly diagnosed by the echo and the CMRI. There's another limitation, which is the factors that may affect the calculation of the SUV, which is the glucose level, the insulin level, the time of the image acquisition, and the FDG dose applied in the exam. And it may vary this SUV calculation from examiner to examiner. Also the variability on the normal myocardial FDG uptake, which may difficult the differentiation, the create contrast, and also the increased uptake in different conditions, such as inflammatory process, epicardial and pericardial fat, the hypertrophy, the lipomatous hypertrophy of the interarterial septum. So it's important always to correlate the PET image with the anatomic imaging of the CT or the MRI in order to improve the accuracy of the differential diagnosis. For the future, we have the junction, the merging of 2 very established methods: the CMRI providing high resolution images of the anatomy, the morphology, cardiac function, and tissue characteristics, while the physiological process images from the PET. In the heart, for cardiac applications, in combinations, the PET-MR may show a synergistic value, correcting movement and throwing less ionizing radiation to the patient. On this study and this case series, published in 2015 on the Journal of Nuclear Medicine, 20 patients with cardiac tumors were assessed by PET-MR, and he established a cutoff, the Cevmax of 5.2, reaching 100% sensitivity and specificity. So the FDG PET-CT is already an established method in oncology, widely available in metastatic cardiac tumors, but in primary tumors, we saw here that is a useful method to identify a malignant tumor differentiating from the benign tumor, and also the staging of the malignant tumors. And it also can be used on the evaluation of the early metabolic response under therapy. Turn on my camera here. So after all that's been said, I think the FDG PET-CT showed this value on the approach, on the diagnostic approach of cardiac malignancies. And I think it cannot be ruled out of any algorithm of diagnostic algorithm of cardiac tumors. And thank you all. I'm grateful. And thank you again, Simone and Steve and Veronica, everyone, for this opportunity. I'm thrilled and hope you all enjoyed this presentation. Now, if you have any comment, any questions, if I'm able, I'll respond. I'll answer. But if not, if it's beyond my capacity, I think Simone can help me on the discussion now.
Hi, everyone. Congratulations, Luca, for your wonderful presentation. Your future is very bright. I can see it. And I would like to invite Dr. Simone to say some words about this excellent and special method of diagnosis. Now we could feel how important is the multimodality imaging in the approach of the right diagnosis in cardio-oncology. So clinics with echo, MRI, PET, CT, so everybody has its value in the diagnosis of these interesting cases and so challenges one. So Simone, please, the word is yours. Please be free to make your comments and thank you again.
Hello, Veronica. Hello, everyone. Thank you, Luca. Your presentation was very, very good. You are excellent.
Thank you, Professor.
Student. Good evening, Steve, to everyone. I think FDG PET-CT, as you could see in this presentation, it's a powerful tool to differentiate cardiac masses. Especially, we have doubts when you do echocardiography on the cardiac resonance, and you have doubts if you this tumor is really malignant tumor. So FDG could help differentiate between it's benign or malignant, and the same time, if this mass is malignant, you could stage the patient, and because you do the exam the whole body, so you can see all the parts of all the other organs and the parts of the body of the patient, and really state or affirm that the tumor is only in the heart, or the patient have metastatic disease in all parts of the body. Sometimes you have doubts too if the mass that you identify in the cardiac cameras it's a thrombus or not. So a PET-CT is good to this condition to differentiate between thrombus and a mass too. This is another case that you can use in the routine, in the clinical routine. So that's it. I don't know if you have some.
Yeah. Thank you, Simone. Does anybody wants to make a comment or questions? Please be free to ask them. Thank you.
So it's Joe Carver. That was excellent. I don't think that we generally think of PET-CT when evaluating tumors, especially when they come primarily to the cardiology service. I think this is a great lesson to take back to my colleagues. I was also impressed with the ECG that you showed with the deep symmetrical T-wave inversion in the inferior leads, which is very unusual. And it may be, you should go back to more simple stuff and see if that pattern is something that's constant in the tumors that you've seen. Because it really is an unusual presentation. And maybe it's a clue that there is some infiltrative disease there that we didn't think of before.
Yes, it's an interesting ECG. And as we saw in the other case series about the MPNSTs, about these kinds of tumor, we see this it's a very aggressive and invasive tumor. So I think by the electrocardiogram we can think about that, right?
Simone, is there any influence of systemic clinical conditions like diabetes, hyperlipemia, anything that could impact in the results and the uptake of the contrast in this situation?
It's an excellent question, Veronica. Luca he spoke a little bit about it. It's very important the patient is in fast, the minimum at least 6 hours, but superior to 12 hours, it's better than 6 because you have decrease the physiological glucose uptake by the myocardial. It's very important to do the contrast because you have a high uptake and the normal myocardial is and sometimes it's very difficult to differentiate where the tumor is, and you have to locate the tumor with the CT image and to see if the uptake is inside or in the tumor, really the tumor, in the state of high level of the glycemia. The patients sometimes have to do insulin before to the exam, so it's not good for us. You have to control the glucose the patient before the exam. So to evitate, how can I say, to in the day of the exam, you avoid to avoid to administrate insulin in the patient because the insulin puts the glucose to inside of the cell, the myocard cell, and it's not good. So it's very important to control this kind of situations. The fasting, it's very important. The other things is the diet. For example, for endocarditis, you have to do a diet with high level of fat and a low level of carbohydrates to decrease the physiological uptake of the FDG. And when you do this kind of thing, you can differentiate, you can possibility that the FDG goes to uptake only in the lesion.
Okay, understood. Does anybody has any questions or comments? Thanks for your considerations, Dr. Joe.
You know what?
I
This was a good hour for me. I always learn something when I join you guys, and it makes me happy to be part of it.
no, thank you.
Luca, this is Steve Caselli. I'm wondering if maybe you or Dr. Simone could comment on how you've changed your use of scanning during the COVID crisis, if at all.
Yeah, well, I think Simone can answer that better than me because my activities are paralyzed now. I'm not really in the field.
In this situation of COVID, when we changed our routine, the number of the patients decreased a lot because the majority of our patients is at risk to progressive to a severe COVID. So you have to take all the care to avoid these patients infected with this terrible virus. I know that these patients cannot postpone your treatment because the majority of PET-CT patients are oncology patients. We know that, but we decreased the number of these patients about 50%. But I know there are some centers that the numbers not decreased, but our hospital, it's a reference in COVID. So all the elective consultations are concealed. So I think because of that, the number of elective procedures and exams are decreased too. And the patients, you have to follow all the cares to
The precautions
avoid,
yeah.
In the reception, the number of the patients we decrease it per day to evitate the agglomerate patients in our reception and either near to exam room too. So we decrease to the numbers of the staff and the all professionals that works in our center, our service. So, and all the patients use masks, and the patients are considered to come to the service only sozinhos. I can to
only by themselves, right? Only alone, with no companions, with no.
Yes, to avoid it. I think the special is the more important.
Simone, returning to the case, I didn't understand very well, please. I'm sorry. Why the fibroma in the study that you show so beautifully? Why fibroma had a very high uptake of the FDG and confusing the diagnosis between a benign and a malignant tumors? So I was very curious to understand the reason that it was the reason that it happened, because fibroma having an uptake of almost 6.8, correct me. So what's the reason for that?
it's difficult to explain the result, but I think some benign tumors that are vascularization too. And the other thing that I think maybe happened this case, to differentiate, sometimes it's difficult to differentiate if the site where you are looking for, it's exactly the point of the tumor, because it's important that the physiological myocardial uptake is very low or nothing, none. So I don't know if this exam there were some kind of these problems.
Yeah, you think probably it was because of the image acquisition or something like that, because this fibroma was from a case series. I don't think they had much information about the calculation and the image acquisition.
Okay, thank you. Steve, the words are yours.
Are there any other, we have time for other questions if there's any other questions or comments. Well, if not, thank you again, Luca, for your excellent presentation. Very interesting cases and great research. We really appreciate you being with us. And we do have weekly webinars now through ICOS. So each day of the week, you can go to our website and look under resources and events, and you'll find information about all our webinars, including COVID webinar next week on Thursday. So thank you, Luca, and thank you, Veronica, for helping organize.
Of course, thank you, Steve. Thank you, Veronica. Thank you, everyone, for watching. Hope you all enjoyed, and I'm grateful. It's an honor, and I'm very happy that you all enjoyed and that I could help you and bring more knowledge to you.
Thank you very much indeed, everyone, and hope to see everybody next month. And please follow the meetings, the weekly meetings from the ICOS. They are very interesting, and we are always learning a lot. Thank you very much for everyone. Thank you, Steve, Dr. Joe, everyone. Thank you.
Thank you. Good night.
Thank you and
Thank
good
you.
night.
Thank you very much.